So I'm going to get us started. I'm going to share my screen and get you to right here. So once again, this is Troy Vander Molen. I'm a doctor of physical therapy, and we're going to share today the truth about knee pain. We've done a lot of these workshops in the last couple, 2-3 months online. I've gotten pretty accustomed to that process. We used to do these live and in person. We hope to do them live and in person again in the future as well as COVID-19 continues to ramp down, hopefully. When we do them in person, it's very easy to interact. I see your face, you see my face. I do demonstrations on actual people during the presentations in many cases. We can't do all that stuff there here that we do there, but I do want it to be as interactive as possible. So those of you on the Zoom call today, you've got a chat button. You hit that chat icon, you type something in, and you'll get directly to me. You'll either pick the panelist or you'll pick panelist and all attendees. I think it defaults to all attendees as well. So if you'd rather me just see it instead of all attendees, you can change that feature. And whatever you type in there and hit return on goes directly to me. And there will be a couple times I specifically ask you to give me some information. We're going to do poll questions as well. I think I have 3 or 4 poll questions because I want some feedback from the people who are joining us today. And I'll give you my direct contact information at the end too. So if you have any specific questions that maybe didn't get covered today, we can talk about those as well. I'll stick around at the end too. Many times people have questions, want to continue the conversation. I'm created some time to allow me to do that too. Just a little detail about me. I've been a doctor of physical therapy since 2013, but I've been practicing physical therapy for 24 years. I have been doing this primarily in an outpatient environment, which means I've seen people with musculoskeletal issues, all kinds of musculoskeletal issues for a long, long time. And I will tell you, I help people get better in much different ways today than I did when I was a young physical therapist. It wasn't that the University of Iowa didn't prepare me well. They were a top 3 PT program in the nation when I went there. But it is inevitable that when you see real people over and over again, that you see patterns develop and you learn what is truly successful for most people. And it is those details that I will share today for those of you that are dealing with knee pain. It can be really, really frustrating, and we're going to talk today about what cumulative trauma is like and how it progressively tends to worsen as time goes by. It's trying to deal with that. It's especially trying to deal with it and then try to do something about it and find that that's not successful. So the goal is, through my experience, to tell you about what I've seen bring the most success for most people with knee pain. I've been with Kinetic Physical Therapy now for a little over 19 years. The company itself has been around for 22 years. We started out with 4 wheels and no walls. And when I joined a few years later, it was 8 wheels and no walls. We did consulting work with industries. But over time, we've added clinics, brick and mortar clinics, where we see people with musculoskeletal issues. And so we now have 7 clinics in central and south central Iowa. Low back pain is the most common condition we see, but knee pain, it's right there at the number 2 level. I did a little math. I think over the past 3 years, we've done close to 25,000 sessions as a group with people dealing with knee pain. And so you're not alone. I guess that's the good news. But it also means that you're going to come someplace that's seen a ton of this stuff and can help you as well. You're going to get information from us. We now have 19 physical therapists. We added a new physical therapist a couple weeks ago. And what I'm proud of are 2 things. Number 1, we have exceptionally good physical therapists and occupational therapists and athletic trainers. And one of the things we do to make them exceptionally good at what we do is that we train them in what's called 3D maps. 3D maps is a way to assess how a body works when you are between ground and gravity. So ground is what's going to influence what happens at your knee and everything else up and down the kinetic chain. We're going to talk a little bit about that today. It's really important to consider those elements when you're trying to help the knee function well and feel better. And you'll understand that a lot better by the end of today's workshop. I'm also proud of the fact that we get a lot of students coming through here, physical therapy, occupational therapy students. These educational programs trust us with their students, and we're proud about that. I like it because it makes us better as physical therapists as well, because these students ask a lot of questions and we need to be able to give our rationalizations, truly understand why we're doing what we're doing, not just doing something out of rote memory or habit. And that's really, really good for us to stay on the top of our game. I want you to know that you are in the right place today if you found, because of your knee pain, that you can't do what you used to be able to do. You're self-selecting and doing fewer things because of your pain. And ultimately that means you're becoming a little bit more dependent upon others. That's the start of a process that generally worsens as time goes by. And I want you to help you stop that process. I've been known to say a time or two that throughout my career, I've seen way too many 60-year-old, 80-year-olds. 60-year-olds chronologically, but functioning and feeling like 80-year-olds because natural processes have accelerated. Things that are preventable have been undealt with, and that's what we're going to talk about today. People that deal with knee pain that is progressive ask questions like, man, is this ever going to go away? Or maybe I need to consider surgery. Do you think surgery would help me? I hear that question a lot. And some even say, hey, if I can't move well, what's this going to do to my general health? We're going to talk about that issue as well. The importance of musculoskeletal health. How well you move will definitely have a direct impact on other things, other really, really problematic health issues that cost people time and unfortunately years to their lives. We're going to learn today, we're going to talk about how your knee is influenced by the things closest to it. And the same is true of you and your community. You influence those most around you, most directly connected to you. And you are influenced by those you're most closely connected to yourself. And we're going to put this in the context of your body. If your knee hurts, that might not be a knee problem. Your knee might just be dealing with issues because of another problem. And if I had to put my talk in a nutshell, that is it. Treating the knee might make you feel better. But if you haven't solved the problem that has caused that knee to hurt in the first place, that's a problem. And so if you're hurt, you're going to feel poorly and you're going to affect those negatively around you. I want you to start affecting those positively around you again. I also want to help you avoid high-risk procedures and side effects of medications that are way too common. What's a high-risk procedure? Any surgery is a high-risk procedure. If you've got to be put under anesthesia, now, it's as safe as it possibly can be, but there are still risks associated with that. We're going to learn today that some of the most common knee surgeries are still not proven to be effective. In fact, conservative care is generally more effective than surgical care. And so why go through a high-risk procedure if you're not going to get the desired outcome from that? Most importantly, if you just want to move more comfortably, if you want pain-free movement, then this is the workshop for you. I will tell you, some of you may be on the call today and find that this is not for you. It is not for you, and you are welcome to leave now if you care to. You have to be in the right mindset to hear this information. And it's okay if you're not there yet. I've had many people come to the clinic for whatever reason. I tell them what it's going to take to get it better, and they're just, they're not ready yet. They're not to that point, and that's okay. You can only change something if you're ready for the information or ready to do something about it. And I wish I could tell you there is a quick fix opportunity here. Most of these knee issues that we deal with are cumulative in nature. We're going to learn today about how cumulative problems tend to worsen over time. Okay, that's the natural process of cumulative issues, are that it will get worse over time. And so if you're looking for a quick fix, you cannot solve something that progressively worsens little by little with a quick fix. It doesn't exist. We're also going to learn about how many of the things we see as quick fixes, medications, injections, and surgeries, might be pain reducers on the temporary, but they really aren't getting to the root of the problem. And so if you're just looking for the quick thing, if you're interested only in masking your symptoms, but not getting to the root of the problem, I've even had many people over the years tell me, I know I just need surgery. If I could just do that, it'll be fine. I'll tell you that that's not going to be the answer for you in most cases. And even if you have had surgery, some people join us and they've already had surgery, and that's okay. The stuff that you will hear today will help you make sure that what you did to surgically repair that knee has the best chance of getting well and staying well too. So that is for you. All right, so I want you to hit that chat button right now. At the bottom, there's an icon. It's a chat button icon. I know some of you have joined since I originally said that. So click on that chat button. I'm going to ask you 3 questions. These are the same 3 questions I ask every person that comes into the clinic to see me, and all of our experts ask the same question when they're working with clients that are dealing with knee pain. So tell me, in the past 2 weeks, is there an activity that you do? If I do this, I know my knee is going to hurt worse. Tell me what that activity is, and then tell me how bad it gets on the 1 to 10 scale. Okay, so 1 means I can just barely feel it. 10 means get me to the emergency room now. This is the worst possible pain. I can't experience anything worse than a 10. And then the third thing is, tell me how long you've been dealing with it, even if it's been on and off. How long ago did it begin? So again, write that down. What activity makes it worse? What's the pain scale? What's the top of the pain scale when you do that? How high does it get? And number 3, how long have you been experiencing it? And I'll see your responses when you type them out, if you're willing to do that. And again, if you are on Facebook Live watching this right now, you can type it on there, and I can get to that later. I will not be able to see those Facebook Live comments until afterwards, unfortunately. All right, don't leave me alone, folks. Give me a little feedback if you would. It's an hour of me talking anyway, so I need some feedback of some sort. That would be much appreciated. All right, we got a chatter. Thank you. All right, so Diana says going down the stairs, about 10 years, 2 to 3 pain. There's some good news and there's some bad news in there, Diana. You're gonna learn that with knee pain, it's almost always a weight-bearing activity. And when you talk about weight-bearing activities that are higher stress, it's either those things where you're going through vertical space or where you're pounding a little bit harder. But it's so faster walking, uneven surfaces, those kind of things. So that's typical, that's not scary. 2 to 3 pain is actually relatively low, so that's good too. The 10 years comment makes it a little bit more challenging. Things tend to get better a little more quickly if we get to them a little earlier too. But then we can still fix that. There's no problem at all with that. Those are good responses actually, Diana. Okay, Leslie, exercise and walking and hiking. So again, weight-bearing activities between a 4 and a 10. So those can get pretty bad. That's pretty significant, Leslie. And then 12 years. So when you're talking about something that's been higher pain for a longer period of time, the quick fix options are certainly less likely to be beneficial for you. We got Tina saying for a year. So that's actually relatively short, even though I'm sure that seemed like a long year to you. It's a stair climbing thing, says Tina, in 6 to 8. And then Linda, side to side movement. Okay, lateral movements, twisting movements with slight bending. Okay, good. We're going to talk about how the knee joint, like every other joint in the body, is a 3-dimensional joint, and it's really made to move significantly in this flexion and extension range. It's called the sagittal plane. But what Linda's talking about is side-to-side movement. That's actually some frontal plane movement, and the twisting is a rotational or transverse plane movement. Those are a little bit more challenging. Even though we're designed to do some of that, those kind of motions are harder on the knee, particularly if you have issues that have progressed over time. And Linda says 10 plus years. Had to use a walker a few months ago, so yeah, that was bad. We're going to talk, Linda, about this bone-on-bone thing. It's a common saying, but it's really, in many cases, an overstatement. It's a little bit of a myth. We'll talk about that today as well. I think that'll give you some hope today. All right, very good. So those are all good responses. Thank you for giving me those responses and for being interactive, so I'm not feeling alone here today. You can see on my next slide here that I actually tell people it's good news. You're in the right place if your pain can be reproduced with an activity. This is good news because if it can be reproduced, it can also be reduced. If it's reproducible, it's reducible. And you can see these 8 things I've written there, those are the most common things I hear in the clinic, and they're all weight-bearing activities. Weight-bearing activities can be hard on knees, especially if the progressive issues there have accumulated over the course of time. And it sounds like most of you have cumulative issues for sure. So let's talk a little bit about this acute versus cumulative thing. You've heard me say the word cumulative a few times. Cumulative is in contrast to this stuff called acute trauma. And so I want to show you on this graph here, we've got on the vertical axis tissue damage or severity, and then on the horizontal axis time and expense. And so I'm going to map this out. When I click the button, you're going to see first what happens when we experience sudden acute trauma that injures the knee joint. Here it is, sudden damage, and then over time, we get better, okay? So the unique thing about acute trauma, things that happen suddenly, it might be a twist, it might be a motor vehicle accident, a fall, something like that. Those things are the result of one issue. So the cause and effect is immediately noticeable. And then when that issue that brought it on is eliminated immediately, the body will naturally heal. Now in the knee, if you have acute trauma, it might mean ligament damage, and ligaments don't repair themselves, depending upon which ligament it is. But the reality is with any acute trauma, it's just one thing that brought it on. Cumulative trauma is difficult to deal with because it's not one thing. It is many, many things. M-A-N-Y, M-I-N-I. And what you're going to see now when I click the button is not just a few seconds, even though that's what it is here, because I can't have you wait for years. What you're seeing here occurs over the course of months and years. And you see the symptom threshold dotted red line? So there's stuff happening, changes occurring underneath the surface that you're not even cognizant of. This is why so many people over 24 years have come to me and said, I don't know why I hurt. I'm not doing anything different than normal. Normal causes things to change. And eventually we get above the symptom threshold. We're going to talk about how human nature's natural response is when we start to experience a little discomfort, we tend to ignore it. That's what people do, especially men, if I can say that. And then I want to show you something using this analogy of the bucket, water in the bucket. Let's do that right now. Cumulative trauma is a progressive issue. It is insidious, but it is very predictable. And so what you're going to see is water filling the bucket here. The first sign that something's happening is fatigue. So tell me, if you're older, 50 or above, even my age, I'm a little under 50, would you say at the end of the week of you doing your normal activities, you have more energy today or less energy than when you were 20 years old? Okay, so it's pretty natural. We do not have as much energy today. We have more fatigue at the end of the week or after doing heavier tasks today than we had when we're younger. That's normal. We're not meant to last forever, unfortunately. But fatigue is the first sign that our bodies are changing. If we ignore that, which most are going to, and more water fills the bucket, now things progressively advance a little bit. And so instead of just having fatigue, we might say there's some stiffness or soreness. It takes a little bit longer time to recover, and it comes on a little bit more quickly when we expose ourselves to physical stress. Again, most people are going to say, you know what, I'm not as young as I used to be. That's kind of normal. And more water fills the bucket. Now we're dealing with pain. Pain is different than discomfort. It's not just stiffness and soreness. It hurts. And I guess the good news is we're not quite to the point where we're dealing with massive tissue damage changes that require more time. We're getting close. All of these things are signs and symptoms that something is happening. It's like the dashboard of your car. In fact, let me go there. Let's say you're driving down the road, one of your favorite vehicles, and your check engine light comes on, okay? Some of you, your natural tendency would be, oh, that dumb light, you know, you can't trust that light. Keep going. All right, so that's fine in some cases, but in this particular case, you get a few more miles down the road and you start to hear something under the hood, and then a little smoke starts to come out and you smell something. It's rattling. So you pull off on the side of the road. You're like, something's got to be wrong here. So you open up the hood and you open up the trunk, okay? Out of the trunk, you pull this thick blanket, big old thick like a mattress, like you put it on the engine, you close the hood. You go to your driver's seat, you pull out a piece of duct tape, you cover up that light on your dashboard. Okay, you're good to go. I tell you this because this is a little bit about how people deal with physical problems. Okay, most of the things that we do just cover up. It's a Band-Aid. It's masking the issue. If we don't get to the root of the issue, that engine is going to collapse, right? If you don't get to the root of the issue with your body, you're going to collapse as well. Now, cars are not made to last forever either. But when we have vehicles at 100,000 that act like they have 300,000 miles, that's a problem. Poor maintenance of the car means it's going to age more prematurely. The same is true with the body itself, okay? So I'm going to turn you into vintage, if I can do that. But that's kind of the path we're on, that progressive path with the buckets filling with water. What have seen for 24 years are people telling me that as this cumulative issue continues, they will say FID gets worse. It's more frequent pain. When it comes on, it's a little more intense, and it's longer lasting than it used to be before it kind of fades back down again. Frequency, intensity, and duration. And by the way, when you get on the right path, it's not going to be suddenly get rid of all those things, but it will mean that the frequency, intensity, and duration goes down. So I cannot promise you at this point you're going to live an absolutely pain-free life if you do these three things. But I can tell you if you do these things, frequency, intensity, and duration, and you're going to get under control. So instead of being on this path, you see that in the distance there, this plane that's train, sorry, it's a train that's rounding the corner here. It's going to be getting closer and closer to you unless you do something about it. And that makes your mood worsen. That means your activity level will decline, and that means health problems generally get worse, and the likelihood of having a high-risk procedure goes up. I'm going to suggest that you do a different process than that. And so look at the bottom here. You see this less pain leads to better movement and better general health. The thing that's in common, the common denominator with musculoskeletal issues, including knee pain, and all those other issues, heart disease, diabetes, obesity, depression, even cancer, those top 6 things are influenced to some degree by how well we move. Now, some cancers are less so, but certainly musculoskeletal issues, heart disease, diabetes, obesity, and depression are all positively influenced by moving well. These costs, when you include cancer in it, make up 86% of Americans' healthcare spend. And musculoskeletal issues are more than any of them. They're the biggest one. In fact, musculoskeletal issues affect more people than heart disease and cancer combined. Okay? And we spend more on musculoskeletal issues than we do on anything else. And so we need to get off the path that we're on, and we need to find solutions. Unfortunately, the natural response does not lead us there. And so in some of my marketing material, I said, I'm going to tell you the number one biggest problem that people make. Here's what I found. People ignore it for too long. And that's not, they do it because they're like, you know what? I can get through this. We're hard workers. We can focus forward. We're not going to focus on this problem. But unfortunately, that means time goes by, and not solving the problem means progressive cumulative issues become more prevalent. And I'll also hear people start to make excuses during the ignoring phase. You know what? I'm not as young as I used to be. Or my mom had a knee problem. I'm probably going to have it then too. It's genetic. These are natural ways of coping with problems, ways that we mentally deal with something physical. We know the physical stuff is not just a physical phenomenon. It affects us body, mind, and spirit. And ignoring it's not going to be good for us. And eventually most people will realize, you know what, I can't ignore it anymore. And unfortunately what we do too often is we find solutions that mask the problem. Either we go online or take an over-the-counter medication. Solutions for knee pain and other musculoskeletal issues are a multi-billion-dollar industry. And many of them are quick fix promises that are not going to get you where you want to go. And I'll raise my hand and say I'm part of the problem. Physical therapists and other people in Western medicine are really good at treating the problem locally, but not getting to the root of the problem. An ultrasound can make it feel better, ice, medications, electrical stimulation, and again, injection surgeries, all those things fix the knee, but don't fix the environment. Okay, so we're in the time of the year where weeds are growing faster than our crops and our grass. If you want to get rid of that weed, you cannot just chop it off above ground. You got to get to the root of that problem. And so I really like that illustration because it highly emphasizes the fact that our problems have roots. And the only way to solve the problem is to take it out at the root. And that's what we're going to talk about, getting it out at the root. So here's a really, really key point today. This is, if you forget everything I've told you except for this, it'll be a good workshop for you. You can't treat mechanical issues with medical interventions, all right? Another way to put it is you can't treat a biomechanical problem with a biochemistry solution. Your knee does not have a dashboard with a meter that says, ooh, look at that. You are low on ibuprofen. If we up your ibuprofen, we're going to solve that problem. It's not it. It's not it. We use ibuprofen to deal with a symptom. And actually, we're going to learn a little bit about why that can be actually something that backfires as well. In fact, let's go there right now. wound healing, whether it's a superficial wound or a deeper tissue wound of some sort. You can see the 4 phases here, and I'm not going to go into a ton of details, but you can see phase 2 right there. It's the inflammation phase. Inflammation is a normal phase in the natural healing process. And so taking an anti-inflammatory, whether it's an over-the-counter anti-inflammatory like ibuprofen, or a prescription anti-inflammatory, will stunt the natural healing process. We need inflammation because it prepares the body for this new matrix of blood vessels. And why are blood vessels important? Well, blood vessels carry blood, yeah? And blood carries the nutrients that tissue needs to be healthy. All right, so let's talk about the heart for a moment. Your heart is a really, really critical organ. It's the most critical muscle in the human body. And that's why when we have issues that clog arteries, that bring blood to the muscle of the heart, a portion of that muscle is going to die. And if it's a bad part of that heart muscle, that can lead to death, very quick death. We do not want that. Now, your knee is not like the heart. If you lack blood flow to the knee, you're not going to die, but the tissue is going to be unhealthy. We need blood and the nutrients that the blood carries for it to stay healthy. And so if we take an anti-inflammatory, proliferation and full maturation is not going to occur as effectively as it would if the process can continue. So one of my favorite authors of all time is C.S. Lewis. Maybe some of you know him. He passed away many years ago. He wrote many books, and he wrote an essay during the time of World War II entitled Miracles. And I'm going to quote this. The quote that I pulled out of this essay is this: "The magic is not in the medicine, but in the patient's body. What the treatment does is to stimulate nature's functions or to remove hindrances." So why do I tell you this? I don't want to give you the idea that I'm a magician, that I have a magic pill or a magic cure. I do not. No one does. Okay, your chiropractor isn't a magician. Your medical doctor, your family doctor, as smart as he or she is, that person is not your medical savior. They don't have special capabilities, special skills. If we do anything to help you as a physical therapist, as a chiropractor, as a doctor, we've been able to cooperate with what your body was designed to do originally. You were created to heal, okay? And there are things that we do that cause that capability to struggle more. And so what I'm teaching you today is not a magic pill, but a way to stimulate your body to do what the body is naturally designed to do, but because of this progressive issue has not been able to do. That's my promise to you. Let me tell you a little bit about Vicky. Vicky, when she saw me a couple years ago, was about age 60, 61. Okay, this is not Vicky, but I put a picture up of someone that kind of looks like Vicky. And Vicky is not her real name, by the way, either. But the story is absolutely real. Vicky is a person that liked to walk around a body of water, a path around a body of water. She did it with a friend. It was something that was great for her physically, but it was a mental, emotional, and spiritual experience for her to do that as well. She had been doing it for years, and unfortunately, over the past several months, she had been noticing a deep ache on the outside, deep within her knee, lateral knee. And when she got on her feet and moved, it got worse. When she sat down or got in non-weight-bearing positions, it felt better. It got to the point, though, that it was even aching when she was off her feet, and that got her more and more concerned. And unfortunately, she had to pull back on miles, and it got to the point where she had to say, you know what, I can't do it. Things are getting worse. So she went to her doctor. She had got some medications, marginally helpful. Eventually got an MRI and was sent to an orthopedic surgeon. And she was told, you know what, I think you need surgery. We need to make this problem go away. So she had tried all the kind of the natural, or I guess the typical responses, and just wasn't getting better. She came to me because she was desperate, really. And I wish she had got to me sooner, because what we did is we did a pretty basic assessment and found that she had a knee pain. She had issues with her knee degenerating more rapidly than it should, but the issue was not her knee, the issue was her hip. We're going to talk to you a little bit. When I talk about the causes of knee pain, hips are major issues. In fact, hip is a major issue for a lot of musculoskeletal issues. It's the primary cause that I see for knee issues and lower back issues. The hip is a major issue that needs to be given its proper attention. And so we found this problem. We did things to fix what was going on with her hip. She worked at it, and over the course of several weeks, 5 weeks or so, she found out that she was about 95% better. She was back to walking her normal mileage, minor aches at most, and she was enjoying her time together. Her life was changed because we finally got to something that fixed the problem. So I'm telling you, I teach this stuff because of people like Vicky, okay? The complaint, it hurts when I move, whether it's a knee, an ankle, a back, a shoulder, whatever. That is the second most common reason people go see their doctor. And I don't want you to hear what I'm not saying. I have several friends. Some of my closest friends are medical doctors. A couple of them are family doctors. One's an emergency room physician. Their knowledge of the human body in general is simply amazing. They know a ton of stuff. But unfortunately, their musculoskeletal knowledge, their well of knowledge there is pretty shallow. And I don't have a breadth of knowledge about the human body. My knowledge about the musculoskeletal issues is vast. I have a deep well of knowledge there. Unfortunately, people go to doctors and don't often get to physical therapists. I think it's estimated that only 10% of the people that would benefit from what I do well get to me. So that's a big opportunity. That's why I'm talking to you about this stuff, because too many people are getting to people in the medical world that can only help them mask the problems and can't really get to the root of the problem. One of the things that often gets done is people will get medications, and in some cases, the pain's so significant that you might get something called a narcotic or an opiate. And I'm here to tell you that we need to stop opiates. Last year alone, 70,000 people accidentally overdosed from opiates. And you can write this down or commit it to memory. Go to YouTube and look up something about keep the opioids and wolves away. Okay? This is a video made 4.5 years ago by a physical therapy group actually in Colorado. And it's a powerful video. And there are 2 statistics on this video that have stuck with me. I want you to hear them too, because this is really important. Number 1, America is 5% of the world's population, but we consume 80% of the world's opiates. Now, obviously, some of those are illicit drugs, okay? But people take those illicit drugs in some cases because they are hurting physically, spiritually, and emotionally, okay? And sometimes only because they have a musculoskeletal issue. Here's the other statistic. In addition to 5%, but 80% of consumption, if you get a prescription for opiates, 1 out of 4 people with prescriptions will develop an addiction. And so opiates and medications in that variety mask the pain only, do not get to the root of it. They are highly addictive and they kill people. So we need to stop that. During COVID-19, unfortunately, we're seeing this increase in accidental overdose from opiates again. Part of it again because of illicit use, and part of it because people aren't getting their pain managed in other ways and more effective ways. And so I want to do whatever I can to stop that from happening. I had a few years ago, and it's been more than that, 8 years ago, a 24-year-old guy that came and saw me. He was getting physical therapy, but he was also taking a narcotic. And he passed away in his sleep when he was 24 years old from an accidental overdose. So that needs to stop. The other thing is surgeries are increasing. They're up another 150%, so more than double in the last decade. But we're going to learn today that unfortunately the outcomes with a lot of knee surgeries is not good. Movement-based problems need movement-based solutions from movement-based experts. That's why I'm here talking to you today. So let's talk about types of knee pain, the most common. That'll lead into the causes, the true causes. You already know hips are going to be one of those things. I'd let that cat out of the bag. And we'll talk about what successful elimination or treatment looks like. I want you to stop doing what Albert Einstein warned us about. Let's take a look at this knee first. I've been talking too much already this morning. So what we're seeing here, we've taken away all the muscles and tendons. You can't see any ligaments on this either. We're just seeing the bones and cartilage. So your knee joint is made up of the bigger bone of the upper leg. It's called your femur. That's the biggest bone in the human body. The big bone of the 2 below the knee at the lower leg is the tibia, and then the fibula. This is the outside of your knee, a little thinner bone that's on the outside. That makes, so it goes all the way down the outside of your ankle bone that fibula makes up. On the front, we have something called the patella. That's your kneecap. And then you see some cartilage. This cartilage right here lining the femur, right on the femur bone itself, That's called articular cartilage. And then this is cartilage, a different variety of cartilage. It's your meniscus. It's cartilage that exists, two C-shaped pieces of cartilage that exist between your femur and your tibia. And that actually bears some of the weight, creates reduction in friction, prevents you from experiencing some bone on bone when you do that. So like I said earlier, the knee joint is three-dimensional, okay? It's made to operate in three different planes of movement. But you can see 140 degrees in the sagittal plane is much more than these two measurements. So flexion and extension, bending and extending. Like your elbow, the knee is a hinge joint, and so it does that best, okay? But when we have something happening that results in more side-to-side motion, valgus and varus in the frontal plane, it's not intended to move a lot in that direction. And Vicky, my 61-year-old client from a couple years ago, she had too much inward knee movement. Her knee was moving into a valgus, and it was beyond what that tissue was designed to handle. That's what was causing wearing and tearing. A valgus, where the knee falls inward, my right knee falling inward, puts tension on the inside of the knee, but compression on the outside of the knee. And so for Vicky, that's why the outside lateral aspect of her knee was wearing out. But those uneven forces because of dysfunctional movement, causes either friction or tension, or maybe both, which will bring on inflammation, which is what causes pain. And that's why taking an anti-inflammatory can help you feel better. But it's kind of fool's gold. It's a false benefit, because we need the inflammatory process to help healing. But if we have this inflammatory process that continues because of dysfunctional movement, it's not going to heal. You're not going to get through that natural healing process. So that being said, any medication is still not getting to the root of the problem, just trying to deal with the pain. So, and then rotation, the knee twisting just a little bit. It only moves about 5 degrees in that direction. Excessive twisting can lead to ligament damage. That would be more acute as opposed to chronic. I'm not going to go into a lot of details on this, but you can kind of see that I'm trying to tell you a little bit about what we consider, what we call your kinetic chain, okay? Links in the chain. And every link has a job to do. So you're looking at ankle, knee, hip, low back, mid back, neck. And if you raise the arm, shoulder, elbow, wrist, it keeps going. So what we're finding is the knee is kind of stuck between these two joints. It's going to be directly influenced by the hip above it and the ankle, foot below it. And what I will find often is that the knee tends to be hypermobile. It moves excessively. It's not the knee's problem, it's the hip of the ankle. So this is a good time to give you another analogy. I gave you the car analogy. Let's talk about a manufacturing environment now. Pretend you got an assembly line with people along the assembly line doing work on some unit. 3 people side by side, almost elbow to elbow. When this unit comes through, they're doing the work, and they're each doing a little bit of work. They're each sharing the load if it's done the way it's supposed to do. Let's imagine for a moment, one of them says, you know what, I'm not going to do that. Let's say the hip says, I'm not going to do that. One of those members of the production crew says, you know what, I'm not going to do it. The others have to pick up the slack, all right? So at the end of the month, at the end of the year, if this person continues to do less than what he's supposed to be doing, what impact is that going to have on the person to his left? And what impact is that going to have on the person to his right? And if I go to those people that are hurting, okay, the knee and the low back, and say, hey, I'm going to rub that down, I'm going to make it feel better. If they could talk, the knee would tell me, well, that feels fine, but you're not getting to the root of the problem. I'm getting stressed because of this guy up here. My neighbor is negatively influencing me. And I will tell you, that analogy tells you everything you need to know about 95% of the people that I see in the clinic. We got to figure out who's not doing his job well, stimulate that person to do his job better, or in this case, that joint, and that will take stress off the knee and allow it to go through the natural healing process. All right, so let me ask you a poll question now. This is completely anonymous, so no one's going to see your response. I cannot see your response. But if you would, please tell me how old you are. So we've got decades here. If you're under 20, pick the top. And then the decade of the 20s, 30s, 40s, 50s, 60s, and then 70 plus. Now, I will tell you, when I've done these workshops, a great majority of people that have been online have been 50 and above, and I think 60 and above has been even a much higher percentage. We've got a group here that is pretty much all in the 60 to 69 range. So there you go, good job. So I know exactly who I'm talking to here. At least chronological age, we know what's going on here. All right, that's interesting to know. You'll learn more about why that's interesting as we go onward here. Types of knee pain. I want to tell you that the type of knee pain is simply a description. It's a diagnosis. You cannot go online and say knee pain exercises. Well, you can. You'd find some. But they're not going to be effective, probably because those exercises are designed not for knee pain, but for specific causes. You can only fix the knee if you know exactly what's caused the pain. And so while we're interested in understanding what type of knee pain you're having, there's more important information. We are going to talk about arthritis, meniscus injuries, and then kneecap issues, patellafemoral pain. Okay, let's go to osteoarthritis. So you can see the x-ray right here. This is a backside view of a person's left knee. And let's just look at joint space, the outside or lateral aspect of the left knee versus the medial or inside portion. It's pretty clear that one is narrower than the other, right? This is narrowing. So this likely is the result of a knee that moves laterally, a little bow-legged. Bow-legged people have more pressure on the medial or inside of the knee, more tension or less pressure on the outside or lateral side of that thing. So this is definitely reduced knee joint space. Some might even be told that they have bone on bone here. This is not the case. Joints have two bones coming together, okay, but they don't come together. If you truly had bone on bone, one bone would be touching the other. There would be mechanical blocking that occurs. So as long as your knee still moves, you have some space. Now, I'll have lots of people that tell me they can bend their knee, and the knee naturally is going to bend 125 to 135 degrees, maybe a little bit more in some. And I get some people that come in, they can't move more than 90 or 95. It is possible that the farther they move, the more those structures get closer and closer together, and there can be a little physical blocking occurring eventually. And that mechanical pressure can lead to changes to the meniscus, where it wears out. Or remember I talked about that articular cartilage that was lining this femur bone. You got some of that actually on your tibia as well. I want you to understand that cartilage does not have nerve endings. Cartilage is aneural, and so cartilage damage in and of itself is not painful. And this is proven by the fact that if you do MRI of people 63 and above, that's probably most of this group right here, 76% of these people will have evidence of osteoarthritis. Only 13% of them will have pain. So it's more common to have osteoarthritis and not have pain than it is to have osteoarthritis and to have pain. So my question is, if you can have changes occurring and have no pain, then why would you do a surgery to get rid of the changes? You're not really getting to the root of the problem with that. We'll talk more about that in just a little bit. And people with this osteoarthritis will tell me it's a deep ache or a throbbing pain. For Vicky, it was on the lateral aspect, deep and in there, and that's because her knee was moving internally, which is due to a hip dysfunction issue. But we needed to take the stress off, the compressive force stress off of this area of the joint. And when you take the stress off that area, it feels better, okay? There's less inflammation. All right, so this is a little bit dramatic. This is an artist's rendering, but this is what the development of osteophytes or bone spurs will look like. This is a wearing away of some cartilage. Again, that cartilage is aneural, so you may not even, you won't even feel that. This is what the healthy one's supposed to look like with that. And so this is the kneecap having been removed, so you can see what's going on at the knee joint proper there. But I will tell you that these changes that occur as time goes by are as natural as wrinkles on the skin. And we don't do wrinklectomies, at least not because of facial pain. So there you have it. That's osteoarthritis. I'm not going to go into a ton of detail, but you'll find that if you take MRIs or x-rays of any joint, the prevalence of problems is much more significant than the prevalence of pain. So these are issues with people that are asymptomatic. It's really common for people that have no pain. That's what asymptomatic means. It's really common for people with no pain to have issues. And so getting rid of those issues with a surgical intervention in that sense doesn't make much sense. So I will tell you the false positives that come from diagnostic testing can lead to decisions that aren't necessarily going to be beneficial for you. Diagnostic testing is really important. It serves a lot of other good purposes, but it's not a very good way of determining whether you will benefit from a surgical intervention for a musculoskeletal problem, unfortunately. All right, so let's talk about bone on bone. I already said this. We said that if it actually was bone on bone, it wouldn't move. There'd be a mechanical block. Just normal walking, you have anywhere from 2 to 3 times. In fact, I've read up to 4 times your body weight on your knee. So let's just say you're about 200 pounds. You're looking at 400 to 600, maybe 800 pounds of pressure just from being on your feet. A femur takes about 800 pounds to break. So if you start to move a little bit faster, that repeated pressure on that, that's certainly going to cause femur issues. If you truly have bone on bone and then started adding force to that just from normal weight bearing activities. And so that's not a great thing. And then we also know that if you look at the joint is surrounded by a capsule, okay, that gives structure to that joint. Inside that capsule, then that's kind of the periphery of this fluid inside the capsule. That fluid creates buoyancy. So that actually, it's kind of like a suspension bridge of sorts. Those bones do not physically come fully together. They're suspended inside the capsule. And that's actually why drinking water is so very important, because that improves the buoyancy of the joint and improves the space filling capacity, and it reduces some of the mechanical pressure that can build in that joint. All right, so that's osteoarthritis. Let's talk now about meniscus issues. So remember, the meniscus is the cartilage, those rings on the lateral and medial side. This is the medial meniscus. This is the lateral meniscus. So if we take that apart and we look at just this lateral meniscus, here's a tear on that meniscus, okay? So this meniscus on the very outside has some nerve endings. If you start to get some damage on the very external, you might feel that a little bit because there's some neighboring nerve issues. This deep in the knee, there's not nerve issues, but this will cause an inflammatory response. That inflammation fills the joint space and the joint will hurt because of the presence of inflammation, not because necessarily the cartilage is a painful tissue. It is not, okay? So remember again, meniscus, cartilage, it doesn't have nerve endings. You cannot feel that issue in and of itself. But the damage you see, particularly if it's coming on earlier than it normally would, or it's more substantial than you'd expect it to be at a given chronological age, is a sign of mechanical stress that can lead to friction and inflammatory issues. But those are due to mechanical problems, movement-based issues, and medication and surgeries will not fix movement-based issues, unfortunately. There are some people that get, these are usually younger people with more acute tearing of the meniscus, and that thing flips a little bit and gets in the way, and the joint will actually lock temporarily until it settles in place, then it opens up. Sometimes in those cases, if you have something that locks that knee down, that can be effectively managed with a surgery. But unfortunately, most of the research shows that surgeries are not very good with this. If you're 60 years old or older, you're 70% likely to have this, and most of them do not have pain. Someone just gave me a little comment. Your thoughts on Synvisc injections? So good question, Linda, and I've had lots of people over the years that have done this. To me, it's kind of like taking a medication, and you maybe have heard me say things, and I've not given you context with this enough yet. I don't mind if people take some medications from time to time. I don't think we should take them for long periods of time. And I say that because surgeries, the medications do not get to the root of the problem. I would say the same is true of Synvisc. They're trying to create buoyancy, to create space, to prevent some of this mechanical pressure that will lead to friction, inflammation, and more pain, and more rapid deterioration of that joint. But again, if you have not solved the mechanical issue, that Synvisc is not going to last for you. It will be a temporary benefit. That's what I've seen over the years, and that's the reality. The British Journal of Medicine, it's actually BJM, I put British Medical Journal, but in 2018, they reviewed all of the data on surgeries that were done for people that have meniscus issues, usually degenerative, usually an older population, and they basically found that surgical outcomes do not warrant continuation of the surgery. In fact, they even said, even if they got more data to support it. It would take a lot of data to overcome what they already know about that. There's also been a study done, it's called a sham surgery. So they entered a scope, an arthroscope, into the knee joint line. Half of them, they actually clean that area out, which is all they're doing with those surgeries. It's like getting rid of the bad tissue in there and cleaning it up a little bit. And the other half just simply had this arthroscope introduced, and they did no cleaning out. And they found that the outcomes after the surgery, when they all went through the post-surgical process, were the same. So the surgery itself was not beneficial. I'm not going to go there, but I would just tell you this. Surgical interventions, and again, I understand why people do it. They're sick and tired of having pain, and you can see evidence of a problem. Let's get rid of that problem. It seems to make sense. We are seeing fewer and fewer of those surgeries being done all the time now because the outcomes are pretty clear that at this point they're not really positive. So I hope that answers your question, Linda. I've had lots of people that have done it, and some people love it, and some people say it's not done them any good. But I know that it's not fixed the root problem on any of those people. But even with the use of medications or anything that solves a temporary pain problem, if you're combining that with efforts to solve the root problem, then that can lead to much better results. But it's mostly about getting to the root of the problem. All right, so I've got a side view now, an x-ray, where you can see this kneecap that's riding over the knee joint itself. And then I got this picture of a train. Why in the world do I have that? Well, the knee cap, your patella, I call it, it's a dumb bone. It's only going to go, the train cannot independently go wherever it wants. It can only go where the tracks tell it to go. And so too is your kneecap, your patella. It will go the way the tracks tell it to go. So the kneecap, more than about any other bone in the body, is influenced by what's going on above and below it. So kneecap issues, patellafemoral issues, are almost always related to hip and or ankle foot issues. Patellafemoral problems are undetectable on x-rays. It's really, really common. It's people that go up and down stairs and feel an ache more on the front side of the knee. It feels like it's right underneath the surface of the kneecap. So you're probably experiencing kneecap issues or patellafemoral problems if you're dealing with that. But it's the same issue because of the mechanical movement thing, that one side's going to have more pressure on it than other. There's a repeated friction issue that occurs as a result of that, which leads to inflammation and pain. And it's tempting to take an anti-inflammatory because getting rid of the inflammation will make you feel better. All right, let's do another poll. You've heard about osteoarthritis. You've heard about meniscus problems. You've heard about kneecap issues. Based upon what you've heard, what would you say at this point is the cause of your discomfort, if you had to guess? Or you could say, you know what, I don't know. Or maybe you know it's something else. I've had people on here that have had like a Baker's cyst, for example. That's sometimes a problem. We're not talking about every possible knee pain condition, but we are certainly talking about the most common. All right, so we've got lots of osteoarthritis responses and some patellafemoral kneecap issues too. Okay, that's good. One thing to point out is that osteoarthritis and meniscus injuries often go hand in hand. The more you develop changes due to arthritis, the more likely it's going to eventually affect the meniscus too. I have a coworker who was a little older than me, 2 or 3 years older than me. When he was in high school, he injured his knee playing football. And back then they did ACL repairs. They didn't reconstruct it. They didn't put new tissue in there. They tried stitching it back together again, and it actually worked pretty well for him. They don't do that anymore. Soon thereafter, they started doing replacements because that was not a very good surgery, but he got a good result out of it. When he was in college, just quitting college, he got very active, started doing running and biking, endurance sports, and for 30 years was doing a lot of that stuff. And then about 2 years ago, he did a backwards lunge, step backward, put his foot in the ground, was trying to lunge, and something popped in that same knee again. So long story short, he had an ACL reconstruction. And when they went in there, they looked at his meniscus and they said, you hardly have meniscus anymore. And he's like, wow, you know, I did all that stuff. I stayed healthy. He ate really clean, which is really important. And he actually felt pretty well until he had another acute injury to that ACL, and that old surgical repair was finally done for. And so again, he had lots of meniscal issues and didn't know anything about it. But those two do go hand in hand. Osteoarthritis can lead to more meniscal issues. All right, so when I talk about the cause of any pain, in this case knee pain, what's the true culprit? I've already told you the hips are big ones. We're going to look at the ankle and foot. I've alluded to that already. Believe it or not, middle back issues, thoracic spine and rib cage. Those are important ones to look at as well. And I'll tell you why. That doesn't seem as intuitive, but it is. So with hip dysfunctions, hips are often very tight. They can be overly stiff. Sometimes for some people, they're overly mobile as well. And we're looking for this balance between mobility and stability. It's a continuum. We don't want it to be overly stiff. We don't want it to be overly mobile. We want mobile stability. I call it most stability. And so we need to look and see what's happening at the hip. If it's too stiff, well, how does that influence the people around it, the joints around it? Well, other parts are probably going to have to compensate for the motion that is lacking at the hip. And that's usually your lumbar spine above or your low back or your knee below. An overly mobile hip, I tell people that's like the train switching tracks. If the hip moves too far, the knee is going to move too far too. It's hard for the knee to stabilize that. The knee needs more stability, but it's not designed to stabilize against that well. So it's interesting, an overly stiff hip and an overly mobile hip can have the exact same consequence on the knee, unnecessary additional stresses. Okay, and that was Vicky's issue. Her hip wasn't strong enough, so the knee, the femur fell inward and it created more stress on the knee. Her knee, right knee fell inward, which opened up the inside of the knee but compressed the outside of the knee. And she had deep lateral knee joint ache because of deterioration that was rapidly occurring due to that stress. Think about how we exist today. This generation, more than any other generation, they're doing something technical. They're at a desk. They're sitting in a vehicle, you name it. We sit a lot. And so this angle of the trunk to the femur is often flexed. This hip flexor group, which is a major muscle that connects to your femur, is in a shortened position. So it's not uncommon to have tight hip flexors. When you stand, a tight hip flexor is going to start to pull forward on your lumbar spine, so you can see how that would change mechanical stress on the lumbar spine. When you plant your left foot and take a right stride, the pelvis is rolling forward and rotating over the femur. Rotation is supposed to occur, but if rotation doesn't occur because that muscle's hip, that muscle of the hip is tight, or maybe that capsule is tight, lack of motion there, rotational motion makes this area rotate more and it adds stress down the kinetic chain too. Now I'm talking about one muscle group and the hip capsule. There's tons of muscles. Your glute muscles, if they're weak, they're going to have a bad ability to control what happens down that kinetic chain. So I would tell you, if you've had knee problems and you've received an assessment from somebody, but they have not looked at your hip, it's very likely that the true culprit of your knee pain has been ignored. Okay, so this is what you see. This is what I call bow-legged, or this is the varus deformity. You can see if I look at this right knee, the inside of it's getting more compressive force. The tension is on the outside of the knee. These knock knees, on the other hand, the right knee, you're seeing opening here. So opening on the inside and more pressure on the outside. This is Vicky. She was experiencing this, but it was a hip issue. We had to give her glutes much better strength, which you can't do quickly. It takes time to develop the strength. We're going to talk a little bit about the ankle and foot. And you can see how a fallen arch is going to contribute to the same valgus issues. Stresses that increase compression on the outside of the knee and tension on the inside of the knee. So that's a good way to segue into that. And interestingly enough, the foot's the same way. If it's overly mobile and pronates too much, if the arch falls too much, the knee's going to fall inward. Okay? If it doesn't fall enough, that knee doesn't fall inward. Okay? Assuming the hip's doing its job. And that means we get pressure on the inside of the knee. And so again, the ankle's the same as the hip. We need the right balance between mobility and stability so that we can reduce the motion stress that gets transferred elsewhere. So again, if you have not had someone look at your foot to see how it's contributing to appropriate motion up the kinetic chain, how it's influencing your knee, you may have missed a critical component that's influencing your knee. You might have an ankle-foot problem, but come to the medical professional with complaints of knee pain. What about mid to upper back stuff? This is the one that's not as intuitive. If you can, please, I want you to stand, okay? So I want you to stand. I want you to plant your feet at shoulders width. Keep your feet planted on the ground. Now, I want you to, in your mind's eye, think about what's happening to the arch of your left foot. Okay, feel the arch of your left foot. If you don't have exceptionally flat feet, you'll just feel that arch. Okay, it's got a little contour to it. Now, feel what happens to the arch of your left foot when you rotate your trunk to the right. Okay, do that a few times. Every time you rotate to the right, what's happening to the arch? Now, this is not true of everyone, but for most of you, when you rotate to the right, that left arch is going to flatten. Okay, and the knee is going to roll in. When the knee rolls in, you get compression on the outside of the knee, and you get tension, separation on the inside of your knee. Same thing now in your left foot, the arch, now let's rotate to the left. And you'll feel that knee start to work outward. When the knee works outward, you get separation on the outside of the knee and pressure on the inside of the knee. And so the thoracic spine, every time we walk, is supposed to rotate. If it doesn't rotate well, stiffness sends compensations down the kinetic chain. So poor thoracic mobility will have an influence on knee stresses, and among other things, other bodily stresses. So just like your hip and just like your ankle foot, a balance between mobility and stability is necessary, or other things are going to pick up the slack, like the 3 people on the assembly line. All right, and so the bottom line is, if you've had knee pain and people that you've sought for solutions have not looked at your ankle, your hip, or your thoracic spine, a critical component has likely been ignored. Let's do another poll here. I'm going to go to poll question number 3, which is 2 questions in 1. All right, so take a look at this. The first one is, if you've seen a medical professional for your knee problem in the past, oh shoot, I totally missed this one. I missed one response. Let's ignore that. Sorry. Usually I have on there, I have not seen a medical professional for my knee pain. The second option is they did a pretty isolated assessment of the knee alone, or they did an assessment that looked at the ankle, the hip, and the thoracic spine. And almost every time I do this, people tell me they haven't had an assessment done, or they've had an assessment that pretty much just looked at the knee. But unfortunately, that option doesn't exist. If you have had an assessment where they looked at your feet, your hips, your spine, in addition to your knee, go ahead and mark that second one down, because I definitely want to know about that. That is not common enough, and it should be more common. The second question is, which medical professional have you seen? And has it been a chiropractor, a physical therapist, personal trainer, orthopedic surgeon, someone in the family doctor's office, whether it's a medical doctor, nurse practitioner, physician's assistant, someone like that. And almost always we get people who've seen their family doctor or their orthopedic surgeon. So far today, we got responses from people that have seen a PT or a chiropractor, so that's good. But I would tell you that chiropractors sometimes take the whole body into consideration and sometimes they don't. And physical therapists sometimes look at the big picture, and physical therapists sometimes do not look at the bigger picture. So my encouragement is, see someone who's going to help you see the bigger picture, who's going to help you understand that your knee is influenced by the hip above, the thoracic spine above, and the ankle and foot below. And because you stand on your feet between gravity and the ground, and all these links in the chain impact each other, you cannot treat the knee effectively without considering what's going on around that area. I'm actually going to go to, oh, that might be the last question. Nope, there's one more. Let's launch this now. We'll lead into these together. If you've had treatment for your knee pains in the past, you can mark as many as you want on this. Tell me what kind of treatments you've received. I haven't had any treatments. Local treatments to the knee, like ultrasound, e-stim, injections, other local treatments, even medications. Table-based exercises, so you were sitting or laying down, or functional exercises, exercises for your knee when you were bearing weight on your feet. The person did manual therapy when I was laying down or sitting, or the person did manual therapy when I was on my feet. Was it one-on-one care, or did the provider work with several people at the same time? And then finally, my treatment pretty much was the same throughout, or it changed as I improved. So tell me which one of those apply, or which ones of those apply to you. And while you're doing that, let me tell you this. I have no problem with ultrasound and e-stim. Like I said a little bit ago, doing some medication temporarily can be a good thing. There are times I do hip exercises where a person's laying on their side. That's not a functional position, but it starts to lay the foundation. And so those treatments in and of themselves are not wrong. they're just incomplete. They need to lead to the next step. And so if you've had all of those things, but you didn't get to that next step where you were on your feet, where you were moving and the body around it was adapting to what was happening, where you were trying to, the provider was trying to train your knee joint to cooperate well with everything happening around it. And in many cases, I'll actually, if we got a hip issue, a hip mobility issue, I'll be guiding that hip motion when I do it. That's what I mean by manual therapy while the person's active. Helping train the hip to do its job well with some hands-on techniques can be really, really happy. I'm glad none of you have seen a person who worked with several people at the same time. Unfortunately, that's legal and it happens, but you are not going to get the individualized care you need if someone's trying to manage 2 or 3 people simultaneously. All right, good job. Thank you, folks. Appreciate your feedback on that. All right, so it's not going to be a surprise at this point for you to hear me say, to successfully treat the knee, you need to get to that root cause. So unfortunately, the most common treatments aren't necessarily the most effective treatments. I've actually added to medications, injections, and surgeries, bracing. Now again, don't hear what I'm not saying. Temporarily bracing to reduce stress on a tissue as it heals is okay. That's like athletic taping for ankle sprains and that kind of stuff. Temporarily, those can be really good things, but long-term, they're not great. In fact, braces or orthotics are going to have a consequence elsewhere too, right? So if we're trying to limit motion at the knee, how's that going to affect the hip above it and the ankle below it? You might be kicking the can to another area there in some of those cases as well. So you have to consider that as well. Knee injections, which are exceptionally common, unfortunately have not been proven to be effective. About 3 years ago, the Journal of the American Medical Association had an article, and they looked at people who had had quarterly steroid injections in their knee over time. And over the course of 2 years, they found that there was more cartilage loss in those that had the injections than those that did not have the injections. And anytime you see more cartilage loss, the likelihood of that person eventually has a higher risk procedure, surgery, which now we know is not really getting to the root of the problem and isn't highly effective, the odds go up. So that's not great. Arthroscopic surgery, I already said what the British Journal of Medicine said. We also know now that about 20% of people that have a total knee replacement continue to have pain afterwards. And again, if it was solely a joint problem, when you replace the joint, you have new joint structures. You should get rid of all that pain, right? Well, the joint may not be the source of the pain. You still might have movement dysfunctions that create an unhealthy joint, an inflammatory process, and you continue to have discomfort with that. So there are many people, I said, we've done everything. You need to have that joint replacement. But I would encourage all of you to consider conservative care before you have a joint replacement, because even if you do have to have a joint replacement eventually, you have prepared your body for successful, efficient movement so that you're more likely to have a positive outcome from that experience. And most doctors do what's called joint camp before joint replacement, where you learn some exercises. I am biased as a physical therapist. I think it should probably be more advanced than what it is, but it's certainly better than nothing. So my encouragement is stop ignoring the root of the pain and seek successful treatment. Now, I've given you a ton of information. I have not been coy. I've been pretty direct with you. And so I'm going to say with you, I think you're going to feel like you understand this condition better. I would assume that most of you at some point in time said, okay, that makes sense. I resonate with that. That sounds logical. But I also want to tell you something straightforward. Just hearing this information and knowing about it and feeling better because you know something is not going to help you. The only way you're going to get better is to take the information you learn and implement it and get involved doing something that is individualized for you, that takes into account the entire kinetic chain, where you are educated and empowered. And what I mean by that is what you're doing today should, if you're getting better, should change. So in a couple of weeks, you probably need to be doing something different to progress. To overcome this cumulative process, you got to drive it back down with cumulative interventions that are functionally focused, where you can work one-on-one and hands-on with someone. And this is what it looks like. Instead of it getting worse over time, you're going to drop it back down. You'll have a much better chance of living longer periods of your life without those symptoms. And so, as I said earlier, knowledge is not power, even though we say that. Implementation is. And so what I want to offer to you, for those of you that have stuck around to the end here, is a free consultation. Absolutely free. There's no cost or obligation, but instead of spending an hour online, it's spending 20 minutes directly with an individual, one of our movement experts, who could do a quick assessment and say, okay, here's the type of pain, which you probably already know. Here's what the true problems are. This is really a hip issue. This is really an ankle issue, maybe a thoracic spine issue, maybe a combination of those things. And based upon that, here's what we need to do to take the stress, the mechanical stress off of your knee, and more than anything, give you confidence, direction, and hopefully some hope. At Kinetic Edge, our mission is to transform lives and restore hope through movement. And one of the big reasons I do this is because I see too many people who've kind of thrown in the towel, accepted the status quo when something could be done about it, okay? And that something can be done in a way that stops wasting your time and your money because it focuses on the root of the issue, okay? All right, so if you're interested in that free screen, by the way, it would be normally $150 worth of value. We're not making you pay for that, and we're actually giving you a guarantee. If you come in and say that was a waste of my time, just tell us. The $150 you didn't give us, we will give to your favorite charity. And we like doing that, but I'll tell you, we've never done that for any one of these because it is a valuable thing. People get value out of it. At the very least, you will have a consultation summary that says, lists out exactly your problem. It's a roadmap for you. Like I said, the type of pain, the cause of pain, and here's what it takes to get rid of these core issues. And that's yours to take home with you. Now, there's two ways you can sign up for this. You can either get your phone out, turn on your camera, and put it on that QR code. It'll pop up a link that you can get to, and that goes right to our website. You just give us your name, your email, and which screen, clinic you want to do the screen in. But if you don't want to mess with that, just on the chat box, just put, hey, yeah, I want that. I'm in. For your information, we also have an online option if you're not comfortable coming in just yet. We are really close to our pre-COVID levels again. We've been using all precautions. People are finding value and coming back in again. But if you're still not comfortable with that, that's completely fine, and we can do it online as well. We have clinics in Ames, Waukee, Des Moines, Newton, Pella, Oskaloosa, and Centerville. So if you prefer a physical location, the one that's closest to you, you can do it that way, or you can just type in the chat box, yeah, I want to take the opportunity to do that. So let's see, I had someone respond here. All right, yes, Linda, and I know where you live, so we'll get you in locally. Diana, you're interested in Centerville. That's awesome, great. We will definitely get you up for that. Anyone else, you can go ahead and do that, or you can, oops, I better not cover up this QR code. I'm not sure you can see what I got on here. This is my direct information. This is my cell phone. You can call or text that. This is my email address. You can email me directly. If you respond to one of the emails that we got, it gets to me eventually too. And you will get an email after this event today with a link to this video. If you have family or friends that are dealing with knee pain too, and you think it'd be beneficial for them to hear this, you can forward that to them. That's great. And we'll be doing, every couple of weeks, I'm doing a knee workshop. So we'll continue to advertise that as well. Tina, yes, we will get you set up in Oskaloosa. You guys can expect a call on Monday. I'll have one of our friendly care coordinators call you to get you set up for a time that works really well for you to make as convenient as possible. All right, I'm going to stop share here a little bit. If anyone have any questions they want to direct to me before we close it up here today? Happy to answer them if you have any. All right, now if any of you change your mind and say, yeah, I definitely want to have that screen, just respond. I think that email we send you gives you the opportunity to respond. I think she includes a link on there. You can click on that link and that'll go to our website, and that gets to the appropriate clinic and they will call you as well. I appreciate you giving me time on a Saturday, an hour, maybe just a little more than an hour of your time. It's my pleasure to help you, and I hope that you found the information valuable for you. And for those of you taking us up on that free consultation, congratulations for taking another step towards finding some more solutions for what you're experiencing. So have a great weekend. Enjoy your time. Find ways to exercise and find ways to improve your body, mind, and spirit in this beautiful weekend weather. Take care. Thanks, Leslie. Thank you, Tina.